Me and Dr. Balanek work together, so the purpose of this class is for the novice to become competent, and then also so that we can identify the experts on Foley's and irrigations, and then the competent will become experts eventually.
Well, thanks for having me here today. Those of you who don't know me, I'm Dr. Roberts, and you've probably seen me around on here. So we're going to talk about catheters today. And before we start, everybody always asks, well, why would you go into urology? What kind of life is it being a urologist? Well, we all choose our professions because of our childhood, and that was my childhood. So anyhow, our whole key today is to kind of help you guys learn how to put catheters in, and make sure you do a little bit, improve your techniques, little hints that will help you. And if you pay attention to some of these things, you'll really improve things, and you won't have problems getting catheters in as much. Number one objective, though, is to make sure you don't have to call us to put them in. So these first two things are true things. There was a guy who was going to have a carotid endarterectomy, and the OR, while the patient was asleep, tried to put a Foley in. They couldn't put it in. So they went along with the operation. They jumped the patient onto the ICU at the end and said, hey, call urology and have them put a catheter in. So you sit there and say, well, why couldn't they get a catheter in during the hospital while the patient was asleep? The patient was relaxed. He should have been able to get it in. Well, it turns out in the urethra, if you kind of look there from the tip, you kind of see the urethra going all the way up through the prostate into the bladder. This guy had a stricture. So when you go to put that catheter in, you hit that bump, and there's no way you're going to be able to get a catheter through there. So a lot of times when you can't get a catheter in, there can be a reason why you can't. But then there's other reasons why you should be able to get a catheter in at all times. And again, when we go through the urethra, if you look there, you see the 5 numbers. You see the navicular, or the opening. You see the long area, it's called the penile, then the bulbar, then the prostate. And the membranous is where the sphincter is, and that's usually where you get caught up. Because usually if it's a guy, they're going to be very tight, and they're going to be tightening up, and they're having pain. And if that sphincter is tightened, you're never going to get a catheter through that area. This was another OR patient. This was a Sharp hospital, not here, where a guy had a TURP. And sometimes when you get a TURP, the area can scar down. If you look over here on the right picture, that's what happens, is that rather than being a nice wide open circle, you scarred down, you just had that little area. And if you try to get a catheter through there, you're not going to be able to do it. And so the OR nurse took the catheter, went to put in a 16, it didn't work. They put in a 12, or a 16 Coudet, and they pushed it in, and then they blew the balloon up, and then they said, oh, it must be in the right position because the balloon blew up. And they pulled back on the catheter, and the catheter came out the right way. Then when they started to position the paper, the catheter was actually coming out the rectum. True story. Bad part is the surgeon, the orthopedic surgeon, wanted to keep on doing the operation.
Oh my goodness.
Now, he was a Kaiser physician, he wasn't a Sharp physician. So, we want to learn out how not to have problems happen. And if you look right here where the catheter, this is kind of a recreation, but basically where the sphincter is, that little white line, you watch the catheter going in the penis, you see the white line right before the prostate, that's kind of where you get most problems with the catheter. That's where the sphincter is. And if you look along here, you have the tip of the penis, you come along, you have the big wide open urethra. And then it tightens up right where it says external sphincter. And that's where you get most of your problems, right at that area. And there's a couple of tricks you can do to get catheters through there that makes it easier. And again, here's another picture. This is called a retrograde urethrogram. And if you look right now, if you look where the penis is and where things are coming down, what are you seeing? What kind of angle is that? You've got a right angle where it's coming down and then straight up. And that's pulling the penis straight up. When you do that, you're getting that right angle. So I know in nursing school, everybody's taught to take the penis, pull it straight to the ceiling. And that's exactly what it's going to do. It's going to give you a right angle to get a straight tube through. So we're going to show on that and kind of, oh gosh, I ran out. What did I hit?
Press the slideshow up top.
We're okay. So again, right here, I forgot I have this pointer. That's I should be using as a pointer. So right here, you know, the urethra comes along, you hit the sphincter right here, you go through the prostate and into the bladder. And again, if you pull the penis straight out right here, it's coming in and it's a right angle. And it would be nicer if everything was a straight shot like this, and that's what you want to do. If it's a straight shot, then all you have to do is worry about the sphincter and the catheter goes in. So how do we get the penis to go from a curved spot to a straight shot? Well, actually, if you pull the penis down rather than straight up. So in nursing school, you're taught to pull it straight out, pull it to the ceiling. Instead, you pull it down to their knees, down to their ankles. And I'll show you that in a minute. So again, same kind of thing. The parts of the urethra, you have the wide open urethra, then it gets tight back here. Same thing as you're looking at the urethra, and this is what happens. The sphincter comes in, it gets tight, and when you're trying to get catheters in, this is where you get false passages. It kind of goes to the back, it goes over here, it rips out here. The balloon gets blown up in this area because the guy's clamped down. And again, more of the same thing, just showing the sphincter, prostate, and then you're in the bladder. Now one thing, once you're in the bladder, usually you're going to notice that you're going to get return of urine. So that's the other thing you want to look at. You want to make sure you're getting urine before you put in the catheter. As guys get older, the prostate gets bigger. When it gets bigger in the center. So when you're going to put a catheter through, you're going to have a little bit of tightness at the sphincter. You also have a little tightness here in the prostate. Now if they have had a TURP and they have a bladder neck contracture, it's going to get caught up right around this area, because that's where the scarring occurs. But again, older guys, you're gonna get through the sphincter and then you're gonna feel a little tightness because the prostate's bigger. And again, here's another picture. It just kind of shows when the prostate's bigger, you don't have a nice channel to get through. With women, it's kind of more of a simple thing. I mean, women always have the urethra anteriorly right here. And with the women, you just have to know your anatomy. There might be things that make it difficult. It might be the lady's really heavy. It might be that she's had a hysterectomy and this area is bulging out. It might be that she has a little stricture in this area, but the urethra is always going to be in that same spot. And so with women, it's anterior, it's going to be right there. You might need a smaller catheter, but that will help you. So with a little bit of history, you have to learn a little history when you do this. The urologist who invented the Foley, his name was Frederick Foley. He invented the Foley in the 1930s, and unfortunately another guy came in and got the patent. So a guy named Bard, who makes Bard catheters, he came in with a patent. Foley ended up dying of lung cancer, broke, but that's kind of what happens when you invent things. And then we go with something called French size. You know, we all have these catheters called French size. Where did that come from? Well, there's a French guy named Charrier who came out about 1900, and he invented things, and he came up, like French, they make everything very difficult. But a French size is just 4 times the diameter in millimeters. So a 12 French catheter is 4 millimeters in diameter. A 30 French catheter is 10 millimeters, or a centimeter. And so that's kind of how it works. It's about 3 times the millimeters is what you're seeing. So your average Foley kit has all this stuff here. And one of the things that you have to pay attention to, you always have your fluid. What kind of fluid do you put in the catheter? Saline. What happens when saline evaporates? What does it become? Salt. What happens when salt gets stuck in a tube? It becomes very crusty. So, if it's going to be a catheter, it should always be sterile water. If it's going to be a catheter that's going to be in longer than a day or two, you definitely don't use saline. For a day or two, it probably doesn't matter. But if you have a guy who you put a catheter in, then he has a stroke, and then he goes over to rehab, and he has a catheter in for a month, when you go to take that catheter out, a lot of the saline will encrust in there, and you won't be able to get the catheter down. And that's a whole nother thing. Then we start needing to either take a big needle and put it in under ultrasound. Sometimes we cut off the balloon port right here and we put a little wire in there, like a small wire like you use for a central line. But again, water is what you want to use for that. And the other thing that always comes in these kits, usually they often have a syringe full of KY jelly. And we're going to talk about that in a minute. That's something, if you have that, it's a good thing to use when you have tough catheters, and you'll see why. And again, your different kinds of catheters, all our catheters have a little balloon on them. They have holes. And you have a Coudet tip catheter here. It has a little bend on it. And then you have the other kind. Now with a Coudet tip, you always have this thing bending up. And actually I have this thing, this is reversed. Whenever that's bending up, you always have a little bump on the side where it's bending up. And you always have this little thing on the side where it's bending up. So in other words, this catheter would be bending down. And this catheter here, you'd be seeing this up. Does everybody understand that? So when you're passing a Coudet, always keep the balloon port up, because that's where your ski is. Now, what else is the difference between a Coudet tip catheter and a regular catheter? Anybody know the difference besides? You can see it there in the picture, but barely. Now, balloons are about, oh yeah, balloons look a little different, but they're basically, you know, it's a balloon. What else do you see? It's turned up, yeah, this is turned up, and that's why, but what's happening here? How many holes do you see there?
One.
How many do you see here?
Two.
Yeah, so what happens if you put a Coudet tip catheter in for somebody with bleeding? You're only at one hole. So realize that anybody with bleeding, you want to have a catheter that's a little bit bigger. Number one, you should probably have at least a 20 catheter, but you also want something with more holes. So although sometimes we're forced to put a Coudet in, realize if you put a Coudet in for bleeding, you've got one hole and it's not going to be real good. So that's less than ideal. Okay? Three-way catheters, you guys have seen those. We use those for CBI, and Dr. Garland will talk about that. And again, they usually have a little bit bigger balloon. They have a 30 cc balloon. Something here you also taught in nursing school. Testing the balloon. How many people here have actually seen a balloon fail? It used to be about 1 in about 100. This is about, you know, I started about 30 years ago, would fail. It was that high. Nowadays it's like 1 in about 1,000, 1 in about 2,000. So one of the problems with testing the balloon, especially in guys, is that when the balloon goes down, you're then going to have more friction there. So then you're trying to put a catheter through where there's friction. So you really shouldn't test the balloon. Okay, that's something that I would never do. I don't think it's worth doing. I know nursing students tell you you have to do it. You might even put it on your boards, but they don't fail. And the reality is you're hurting yourself and making it tougher. And right here you have the other problem that we talked about. What are they doing? You've got your paper right here.
Oh, sorry.
Thanks. What are they doing right here? They're pulling the penis up to the ceiling, right? And although that's real nice to get into the meatus, it gives you that right angle. So you really don't want to do that. For yourself, always get the patient and yourself in a position of comfort. Raise the bed if you have to. Make sure you have everything available. And if you need assistance, get assistance, especially in women. So again, never test the balloon. Never force anything. Again, if you're pushing and you hit something, stop. It should go pretty easily. And never blow the balloon up without flow. So what does that mean? If you don't get urine back, you shouldn't blow up the balloon. Now, if you don't get urine back, what's the most common reason you think you're in, but you don't get any urine back? No, you're in the bladder, but why don't you get anything back? Something blocking it. What could be blocking it? Lubricant. Number one would be the lubricant, exactly. So again, realize that lubricant that you put in there to grease, you know, the catheter, it can clog the hole, and it can take a couple of seconds to do it. So once you put the catheter in, and you think you're in, you're not getting anything back, you can push on the belly, which will usually at least put a little pressure, and that'll take that little clog of lubricant and force it through. The other thing you can do, which nurses don't like to do, is that catheters, of course, come connected. Why do they come connected? You know, where the catheter is hooked up to the drainage bag? Sterile, right. They do that for sterile technique. The only problem with that is that makes it more difficult to pass a catheter, makes it more difficult to work things. So if you still don't get anything out, break the seal there, take the balloon catheter that you filled up the balloon port with, put it against the end of the thing there and just pull back, and that little catheter will give you a little bit of suction and you'll get your fluid. So you always see me doing that. And so either flush or irrigate or just pull back with that little balloon. That's a nice simple way when you're in there. Okay, now this is what we were talking about before. When you just kind of leave the penis where it is, you get this curve in there. You take the penis and you pull it, and pull it down to the knees. Pull the penis straight. In other words, here's the penis. If you pull it down this way, then you're going to end up taking that the area out, the bend. Where if you pull it straight up, you're going to have a right angle. It's going to be harder to go. So on guys, you can be gentle, but you still just want to pull down. Pull down to the legs, down to the knees, and then you put the catheter and you have a straighter shot. So again, right here kind of shows it again. Here's a penis that's bent, comes down, it has to turn right. Penis that's pulled down, it's a little straighter, and if you pull it straight, it works a little bit better. But you want to get rid of this bend here because you're going to lose things there. This thing right here, this thing took me probably 20-25 years to learn how to do. When you pass a catheter, I don't think I can go back, can I?
I can do it for you.
Yeah, so when you pass a catheter, the catheter usually gets caught right here at the sphincter. Catheter's going in, the guy's a little tight, it gets caught. If you spin the catheter when it's going in, it's going to find the lumen naturally. So in other words, as you're putting it in, you're twisting. Now, it's a little difficult when you have everything attached, but you can still do it. And usually what I tell people to do when it's attached is, when it's attached, pass it straight until you get to about this far in, and then start spinning. Because that's about the area it's going to take you to get down to the sphincter. Okay? But if you ever pass a catheter, you have trouble, and it's not working, then break the seal, start again, and just spin the whole time you're going in. Twist it as you're going in. Because what will happen, that catheter will come right in, and instead of plowing and going outside and making a false passage, it'll spin and it'll just find the lumen naturally. The other thing it'll do is if the guy has some strictures, remember we talked about strictures, where the urethra gets all tight, it's more likely to go through a stricture if it's spinning than if you just try to plow through it. So spinning a catheter really will help it. It's a great trick and something that works well. This thing's important too. Get your patient relaxed. With women it's important, but with guys it's even more important. Women it's important to have the legs relaxed so you can get to the urethra, but with guys, if their sphincter's tight, you're not going to get it through. They're just going to, if they're just tightening down. So you can tell them to relax, tell them to breathe. And if you get the catheter in about that far and you're hitting a point and the guy's like this, don't keep pushing. Just stop and say, okay, let's relax. Let me hear you cough. And the guy will, and when he coughs, he has to breathe afterwards and you can kind of push it through. Or you can just breathe in and out. To have him do like his pregnancy breathing where he's unfortunately some guys will hyperventilate doing that, but at least you'll get it through that area because it's tight. It's tough to tighten your sphincter if you're breathing. Okay, so get them relaxed. If you get them relaxed, the sphincter will go through. So that's another thing that's really important. Relax sphincter, spin the catheter, and straighten the area out. Okay, we talked about balloons again. So again, balloons, you've seen them on every catheter. We don't want to blow them up because it increases friction. And we also talk about, the holes, 2 holes being on the catheter. So a 5 cc balloon. How much can a 5 cc balloon hold? Anybody know? Well, what do they give you usually in your Foley kit? 10. So at least you know it's 10. You think you can hold more than that? Anybody get this? I'll buy him dinner.
No.
Yes.
Say
Yes.
What's your number?
18.
No.
30.
No.
20.
No.
15.
This is like the price. This is like the price of right. Let's go higher.
25.
Let's go higher.
15.
25.
Go higher than 32.
35.
34.
37.
36.
Go higher.
42.
60. Do I hear any higher?
67.
77.
85.
100. Higher.
150. 150. 135.
Higher than 110. 150. 15. So, that's true though.